Okay, so my name is Janaea Beaton-Burden, and my capstone project was on preventing obesity in children and adolescents. My abstract, preventing obesity in children and adolescents. Adolescent obesity should be of great concern to the public health professionals. It is much more than just being a bigger person. Having excess body fat increases the risk for other chronic conditions such as diabetes, hypertension, asthma, and sleep apnea. Intervention proposed for this concern is an educational workshop along with free nutritious groceries. Effectiveness of this intervention will be ensured by using the health belief model and the MAPIT model. Expectations are high attendance and retention rate of participants, retainment of knowledge about health and nutrition, and change of lifestyle choices. Introduction. So, children's weight is of no fault to them. After all, their parents make their meals every day. Very rarely do you have children of young age who are able to prepare their own meals. Here you see a boy who is eating, it's just a picture, of a boy who's eating carrot sticks just to show that it's possible to lounge around and snack on something healthy versus lounging around and snacking on chips or fries or ice cream. So again, parents choose what and how much to nurture their children with. Many families, they lack the health literacy about appropriate amounts of food to feed their children. Some people just don't know what a serving size is, and they don't know that they, as an adult body, should not be feeding the same amount of food to their children. And some people don't know that. So those poor lifestyle choices, along with genetics, are going to make children and adolescents more vulnerable to obesity. A bit of a literature review. Here is a picture at the bottom on the right. The left is a picture of normal adipose tissue fat cells, and the right are obese adipose tissue cells. This is what an obese person would look like on the right. Their tissue cells swell, and when they swell, you can see that there is vascular rarefaction. Those are when the blood vessels are constricting, and that's what's going to cause other chronic illnesses and down the line. My target populations are definitely children and adolescents aged 11 through 19. According to the World Health Organization, WHO, worldwide obesity rates are 3 times as high today as they were in 1975. That means between 1975 and 2021, the rates for obesity were 3 times the amount that they were in the past. Obesity, just a plain definition in layman's terms, is excessive accumulation of body fat. So the body normally burns calories while we are resting and while we are exercising, but when too many calories are eating, like when kids are eating way too much for their size, their body cannot burn that surplus amount, and it's going to store it as adipose tissue. So you can go back to this picture at the bottom. The left side are normal adipose tissue cells, and on the right is an obese person. Further review. So there is a chart of body mass index called the BMI, and it indicates categories of fat. The BMI, it compares your height and weight, with the result being a number that is going to represent a weight class. Weight classes are underweight, normal, overweight, and obese, but the obesity has 3 classes of obesity, and it begins at a BMI of 30. And this is a BMI chart. It doesn't extend. If you go at the top, it starts at 120 pounds and it ends at 240 pounds. This is one of the only clear charts that I found, but most or some of the other BMI charts does extend past 240 pounds to represent, more obese populations. But just an example, I am a female and I am 5'6", and I weigh about 130 pounds. So if we go to 5'6" and we go to 130 pounds, I am green. And then if we go to the legend over here, green is a healthy weight. Now let's say, I don't know, if I had kids or something and I gained 20 more pounds, life happens, things happen. I am 5'6". I will go to 5'6", and then I'm 130 pounds. Let's say I gain 20 pounds. I would be at 150 pounds. Technically, I would still be at a healthy weight. If I were to gain, 20 more pounds from 150, just because of life and getting older and falling into poor habits, I would be 170 pounds, still at 5'6". Then I would be falling into overweight. When you are at 150 pounds for being 5'6", it's kind of like you're borderline overweight. And I know this chart, a lot of people have their gripes with this chart, and it can be problematic, but it's just a reference. It's just a stepping stone, just to benchmark what things are and what things aren't. You don't want to get into the pink because that can lead to further chronic health conditions such as diabetes, hypertension, sleep apnea, things like that. For example, someone who, I'm just going to go for my mother, who I know is clinically obese. My mother is 5'4", and I'm not going to say her weight, but it's very high on here, and it's very concerning for her doctor. So for someone who is so short to have so much weight, it's not in proportion, and it is not healthy. That is clinically evidence-based. That is not societal. That is not a prejudice or anything. So a lot of professionals will use this chart just to get a reference point. It's not to put anyone down for their weight or anything. It's to watch out for their health. Okay. Further review of literature. In 2018, the CDC reported 20.3% of 6 to 11-year-olds and 21.2% of 12 to 19-year-olds were obese in the United States. 20% equates to about 1 in 5. So 1 in 5 American kids are going to have obesity, had obesity actually in 2018. In 2017, the CDC reported only 1 in 10 Americans were consuming the federally recommended servings of fruits and vegetables daily. For Illinois specifically, though, out of a sample size of 4,685 people, 14% were meeting fruit recommendations, while 9% were meeting vegetable recommendations. And just for reference, the recommended amount for Americans is about 1.5 to 2.5 cups of fruit every day and 2 to 3 cups of vegetables every day. And that is saying for Illinois, they sampled about 4,000 people. Only 14% are doing that, and only 9% are doing the vegetables. That's not good. So we can compare that sample size to the population. I just did a rough estimate. So if 14.1% of the 4,685 people are only eating the recommended fruit serving, I wonder what that would look like in representation for the whole Illinois population, because they only sampled about 4,000 people. So 14.1 times 12,780,000, which was the Illinois population in 2017. I multiplied that and I got roughly 1,789,200 people. So that means I just did a rough comparison, meaning if 14% of the entire Illinois population is only eating the recommended fruit servings of 1.5 to 2.5 cups a day, that means only roughly 1,789,200 people are eating enough fruit. That is not good. We have a population of, it says here, about 12 million. And if we go to, the vegetable, 9.7% of 4,685 people are eating the recommended vegetable serving. So if we multiply that by 12,780,000, which again was the Illinois population in 2017, we get a total of 1,239,660 people. That's not good. That is saying only 1 million Illinoisans are eating enough fruits and vegetables. We are a state of 12 million people. Not eating fruits and vegetables puts the body at risk for collecting fat, cholesterol, and sodium, which are unhealthy in excess amounts. My rationale for the intervention that I would create is because our childhood years are very formative. So the habits we form during this period are going to set the tone for our adulthood. Since habits are hard to break, a child who eats unbalanced meals when they're a kid are going to have a hard time changing this when they get older. A child who is not physically active, they're not going to have endurance or the stamina to begin exercising when they're older because they didn't build up those habits. Positive behavior should change and begin in childhood to set a solid foundation for optimal health. Obesity is not a singular chronic condition, meaning if someone acquires obesity, it's not in a vacuum. Obesity has accompanying comorbidities such as asthma, diabetes, cardiovascular disease, heart failure, myocardial infarction, things like that, and sleep apnea. They may develop as a result of being obese because it's a domino effect with this condition. I'm sorry. So to create an intervention for this condition is to prevent further illness for others to follow. My intervention, I just named it Fit for Me. And up here on the left is a picture. It looks like a focus group or a workshop with some women. And at the bottom on the right, it looks like a health educator who is explaining a diagram. That is, after graduation, that's one of the things I see myself doing, hopefully. And with this intervention, the goals are that families will understand physiologically how weight gain occurs. Families will understand the severity of obesity. Families will understand how to create a balanced meal for their kids. And families will know the 5 components to a healthy diet: fruit, vegetables, proteins, grains, and dairy if they eat dairy. Families will also understand portion control and serving size. I have 2 pictures. I'm sorry about that. Excuse me. I have 2 pictures on the left. At the top is a picture of just examples of what you can eat for proteins like chicken, fish, beef, or eggs. On the right, half of your plate should be vegetables, so like tomatoes, carrots, cabbage, greens, celery, things like that. And on the bottom left corner are what your carbs can be. 1/4 of your dinner should be carbs. At the bottom is just a funny little meme. The restaurant portion, has a lot of pasta, which is a lot of carbs, which is not good if you're eating too much. At a restaurant, they're probably going to give you about 2 cups of pasta, which is roughly 440 calories. And the right portion for me is what we should be eating. That is the portion control and the serving size. Just because a restaurant gives us a bunch of food on a plate, it does not mean we have to eat all of it. You're supposed to take leftovers. We don't have to eat all of that food in one sitting. And you can see that the amount of pasta is less. I'm not sure if the amount of vegetables is less, but it definitely looks like the amount of pasta is less. So that means there will be less calories. Again, just to say splurging at the restaurant and just indulging in good food is not a problem. It's just when we do this habitually and we over consume our serving size, that can lead to obesity after years and years and years. A couple of times a week is fine, but habitually doing this, it will lead to obesity. And having children eat more than what they can handle is going to lead to childhood obesity. Okay. My intervention proposal, it will be a workshop in its educational and financial implementation of a lifestyle change. So the mission is to improve health literacy about their child's obesity. Again, teaching these parents, physiologically what is happening to their child and why they are larger than other children. It is not to be rude. It is not to be condescending. It is just how good are we as health educators, as community health students, if we can't communicate complex ideas to our community? Knowing big words and knowing a lot of vocabulary words, it doesn't really mean anything if you can't communicate that in a way that is easy to understand to families that you're going to be serving. Again, this is a picture of portion control. On the left is what we usually eat: a big burger, a bunch of pickles, tomatoes, onion, everything, a lot of ketchup, and a lot of fries. I love fries. But what you should eat is probably about half the amount of fries, half the amount of ketchup, take a couple of pickles off, okay? And you don't need the entire burger. It's just, as Americans, we do eat more than what we should be eating for our sizes. It's just a habitual thing. I'm not sure if it's a cultural thing. We eat more than we should be eating. And this picture really helps even me to understand, okay, just because you have all of this on your plate doesn't mean you have to eat all of it, especially when you know the recommended serving size for beef. I believe it is 5 or 4 ounces. That burger on the left, that looks just looking at it, it looks way more than 4 or 5 ounces. So you're going to go to the next slide. Intervention proposal. This is just a picture of produce, grocery shop. So my educational workshop is going to be a one-time thing that will teach families serving size, balanced meal criteria, and the severity of obesity. The financial donation will be bi-weekly in the form of free groceries. After families sit through the workshop, they will be allowed to go to the food pantry in the back and they will gather free groceries. The groceries will include fruits, vegetables, proteins, grains, and dairy. They can get a couple from each category because I have taught them how to create a balanced meal. So then they will go to the back, collect their things, and gather things that will make balanced meals for their family. Health belief model. It theorizes that people do not want to be ill, nobody wants to be sick, and they will practice a behavior such as eating the correct serving sizes and recommended fruits and vegetables that will prevent or cure their illness, which is obesity. I believe once my target population understands that obesity is a chronic illness that manifests other chronic illnesses, such as diabetes, asthma, sleep apnea, they will practice positive health behaviors. This is the health belief model condensed. So when you have a high perceived severity, such as when you think about the negative impacts of weight on your heart, your lung, and your muscles, then you will have a sooner cue to action, meaning it will be quicker for you to realize, oh, I'm scared that I'm going to be going to the hospital from illness. I'm scared that I'm going to be stuck on medications that I have to remember to take daily. I'm scared that I will no longer be able to walk or, go up a flight of stairs without feeling tired or things like that. The sooner I realize that my perceived severity is high, the sooner I'm going to just have a light bulb switch for my family. And I say family because my target population is children and adolescents. But, as you know, parents are the ones who are creating the meals, who are creating this lifestyle, who are setting the tone for their habits as adults. So we are really a community when it comes to who I am trying to target for this childhood obesity issue. And then low perceived benefits, such as believing that eating healthier is not going to help your obesity. Some people think that, if they get too big, that, oh, well, I'm too far gone. It's too late. It's never too late to change your lifestyle. So low perceived benefits are going to lead to low self-efficacy, meaning you're not going to believe in yourself that you have the motivation to constantly eat balanced meals to maintain your weight long term. This is what I want to counter when I do my proposed intervention workshop. I will counter this. I will give them high perceived benefits, such as weight loss, such as you will have more energy, such as you will feel fuller off of less food and less calories consumed. And once you have higher perceived benefits, then you have a higher self-efficacy, meaning you will believe in yourself, that you can motivate yourself, and you will believe in your knowledge that I have given you about portion control and about portion size and things like that. And you will believe in yourself that you can do this long term. So that is a health belief model. The other model that I would use for this intervention is the MAPIT model. MAPIT stands for Mobilize, Assess, Plan, Implement, and Track. So for M, mobilize key individuals. So the key individuals are stakeholders. So I thought of pediatricians, nutritionists, health educators. I live in Chicago, so the Chicago Alderwoman, Pat Dowell, from my neighborhood. I would contact her. I was thinking about it just to ask her a question. She is an approachable person. You can contact her for inquiries about city permits, locations to hold workshops, what type of licensing I would need as a student or as a recent graduate, what type of professionals I would need to occupy a building and have food in it and give away food. She would know about all of those permits and everything that I would need if I even planned to do that. For A, assess areas of greatest need. I will conduct needs assessment for the south or west side of Chicago. Those are the areas that have the most prevalence for obesity, because obesity does relate to your income and what you're able to afford. That has a relationship. So a workshop and pantry would be in an area with a high child obesity rates. I would gather data on income levels, number of household members, and kind of see what neighborhood would be best, which neighborhood in Chicago would be best to host workshops and have a food pantry. For the P, I would plan everything with a team. Sorry about that phone in the background. I would create deadlines for gathering data. I would have a lesson plan for the workshop. Again, just like this, a presentation, what I would teach them about serving size, what I would teach them about obesity. I would have the same images that I had here with the adipose tissue and show them what it looks like and explain to them in a way that's very easy to understand, because you want them to retain this information. I would gather city permits and gather participant registry for people who would be interested in this. That's what I would do. For the implementation, I would use social media to share the Fit For Me intervention with the public. I would spread awareness in neighborhoods and schools. I would go to grocery stores, go to clinics, and ask if I can hang up a flyer on their bulletin board. And I would do public fundraising, such as GoFundMe, and try to see if I can get neighborhood and also municipal funding for this. And to track after all is said and done, and after you begin your intervention, your effectiveness has to be tracked. So I would have experienced program evaluators, such as past professors or supervisors, assess effectiveness of Fit For Me. They will assess if the needs and the goals were met. They will assess if the current prevalence of the adolescent obesity compare to the prevalence of obesity before the program, and see if that rate has increased or decreased. And then participating families, they will be surveyed on retainment of knowledge, if they understood what they were being taught, and if they are practicing those teachings to their families. Expected outcomes. I expect for the intervention goals to be met. This is what I planned. This is what I researched. I've done the literature review. I've seen what Chicago needs. I've seen what families do need. I do know a lot of families that have obese children. I know what they need to be taught, and I know what they don't understand. And it's not just about being taught. I know that the social determinants of health, one of them is having access. A lot of people do not have access to healthy foods. We can't just blame obesity on lazy parents. We can't just blame obese children on having lazy parents that don't care about their kids and feed their kids fast food like McDonald's. It's not about that. It's about the opportunity, and it's about accessibility to healthy foods in general. So I know that, and that is why my goals are set not just on education, but on philanthropy. This intervention is a primary prevention strategy, and primary prevention is one that seeks to prevent the condition of obesity from occurring. Education will prevent poor food habits, again, that cause weight gain. So implications. The pros to this are that the intervention is going to give families a conceptual foundation of nutrition and weight maintenance. When people have a comprehensive understanding of how to create realistic, healthy meals, healthy eating is less intimidating. The workshop awareness can be spread by word of mouth, thus increasing more participation. Since the workshop is a one-time visit, but the pantry is going to be a bi-weekly visit, then I will still need more participants in the workshop. So as people visit the workshop for that one time, they can spread the word to their auntie or their sister or their neighbor next door. Their neighbor next door, and I can get more visitors, and I can get more foot traffic, and I can get more people educated about this condition. And having the groceries and having the donations of food, that is an incentive for workshop participation. In one of my classes of research design, when we were talking about doing trials on humans, like when they do human trials, that they talked a lot about not having incentives as money, because you can take advantage of people who are less fortunate and who really do need that money. But in this case, a good incentive is giving away free food, free healthy food at that, free produce, free protein, free grains, free vegetables, free fruits. Things like that are positive incentives that are accepted in community health. The cons of this, though, are that healthy eating for weight maintenance, it doesn't consider genetics and family history. A lot of children are obese at a child age, and you would think, how did they get this unhealthy? What happened? You haven't been here for that long. How did this happen already? And it's because a lot of them are predisposed to poor health conditions because they have a family history. Eating healthy and maintaining your weight may not help for a child who is already obese, who has a family history of obesity. They may need to take other measures as children, engage in sports, swimming, running track, soccer, engage in, child therapy, engage in cognitive behavioral therapy specifically to change how they think about food. Things like that have to be done for people who have a family history. So this intervention does not address the need for physical activity as well. And these are all of my references in APA format. And thank you for tuning in to my presentation. Again, this was about obesity for children and adolescents. And my name is Janaea Beaton Burton.